Thank you very much, and thank you very much, Sushil. That was an excellent presentation, and I'll also try to cover certain part that you already have covered, because until or unless you understand the anatomy and the pathology that exists with that anatomy, a true treatment of recurrent patellar dislocation is not possible. So at the very outset, I'd like to thank NOA branch Chitwan for giving me this opportunity to talk on one of my favorite topic, for which we have been learning for so long. And when in last 1 week, I decided to revise, then you find out that there are so many things that is unanswered. And then it's really going to be a daunting task for me to cover whole recurrent patellar dislocation and its treatment option basically in next 25 minutes. So have patience, let me try how I can do in 25 minutes. So how I have decided to do it is to divide my talk into 4 sections. The first section essentially a modification of what Sushil has already presented. I'll emphasize to understand the recurrent patellar instability and its anatomical correlation. And then second, I'll talk about how to decide which surgery is appropriate for a particular patient. Here, I'd like to reiterate the a la carte approach, which is becoming so much popular nowadays for the treatment of complex patellar dislocation. And I'll share some of our experience at AKB Center. Accumulated over a period of last 10 years. To start with, understanding the patellar stability and the clinical correlation, I absolutely agree with Sushil that we have to know what patella does when there is a movement at the knee joint. So when we move the knee joint, the patella, okay, let me take the laser please for a while, okay. So the patella moves about 8 centimeters from its original position to the notch. So when it moves from its original position to the notch, it passes 3 important landmarks. The first landmark is the flat femur from where it starts. So this is a flat femur. When you gradually flex and you go up to 20 to 30 degrees, you reach to the entry point of the trochlea. And when you go beyond 30 degrees, then you go into the trochlear groove. So the main point to understand that any problem during the tracking of this patella can lead to a patellar dislocation. So if you clarify and group these causes into certain causes, there are 6 different causes of patellar dislocation. I'll try to go through them one by one. So number 1 is the MPFL tear. So when there is a MPFL tear, the soft tissue failed to bring patella into the trochlear groove. If you see this MRI, which was taken in 10 degree, 0 degree, 10 degree, and the 20 degree, same thing, this is the diagrammatical representation. You see that in up to 20 degree, the patella lies completely in the flat surface of the femur. So in this position, as Sushil was trying to say, the main stabilizer is the MPFL. So if someone dislocates at full extension of the knee joint, the pathology is the MPFL. That is a very important point I'd like to highlight. So what happens if there is a MPFL tear? So this is a animation to show the MPFL tear. The MPFL is torn. So when you start flexing the knee, the lateral structure pulls the patella towards the lateral side. So when it reaches to the notch, it doesn't come to the groove, but it hits the lateral condyle and it falls back and the patella gets dislocated. So even if there is not a tear of the MPFL, but if the patella keeps on dislocating, what happens? The MPFL gets stretched. So the MPFL is insufficient. This is the reason why all surgery of the patella dislocation must include MPFL reconstruction, because if it is not torn, it is stretched and it is insufficient. So whatever pathology it is, if the patella dislocates, the MPFL is not functioning. That is why at this moment, all patellar dislocation must require a MPFL reconstruction. That is what the current literature has to say. Second cause of patellar dislocation is Patella Alta. And there are various indices. Few of these indices has already been mentioned by Sushil. I'll not go into that, but I'll show you again an animation which says that as you flex the knee, the patella comes down. If the patella is already high riding, even in full flexion of the knee joint, the patella doesn't engage the groove. So patella still remains above the groove. So there is a chance of dislocation of the patella if the patella is high riding. That means the patella alta. So what you do if there is a patella alta? So what you do is you do a distalization of the tibial tuberosity. So do osteotomy, remove about a centimeter, then pull it down. So if you pull it down, the patella also come down. You see that patella also coming down. And when you flex the knee, now since the patellar tendon is short compared to the patella alta, now the patella engages very well into the groove. So if there is a patella alta, the surgery that is suggested is the distalization of the tibial tuberosity. The third reason for patella dislocation is the trochlear dysplasia. So if there is a trochlear dysplasia, Trochlear does not allow patella to enter into the groove. So as Sushil emphasized that about in 20 to 30 degree of flexion, the patella enters through the trochlea to the trochlear groove. And this is picture at 30 degree of flexion, in which you can see that the contour of the patella very much matches with the contour of the sulcus or the trochlea. So the patella has to come to this one. If this entrance is not correct, like in this case, this is a trochlear dysplasia. If you see that the entrance to the groove is not correct, there is a bump, then what happens? This bump pushes and the patella falls onto the lateral side. If you see this dynamic, hold on, if you see this dynamic CT scan, okay, if you see this dynamic CT scan in which you see that you are going gradually, patella is coming down and the patella is hitting the bump. And this bump is not allowing patella to fall into the sulcus, rather it throws your patella back to the lateral side. So the trochlear dysplasia is one of the bony cause which is very, very important to identify and address. So how to address this is to remove the bump first, make it flat. Once you make it flat, take a wedge and make a sulcus. So this is now new sulcus where the patella will track, and this process is known as a trochleoplasty. So my talk is not on the main technicality of all the surgeries, but I'll just mention that which surgery is going to be suitable. So before that, I am talking about what are the surgeries, basic principle of surgeries that is available. So the fourth reason out of 6 is excessive femoral torsion. So this picture says that if your femur is normally aligned, your patella track matches with the sulcus. You see that if the femur is normally aligned, the patella tracking matches with the sulcus. If there is a rotation, in this case, internal rotation of the femur, and the patella remains in the same place, now the track doesn't match. Actually, the patella has to come from this side. So the track doesn't match. Now again, it hits the bump of the lateral condyle. That Sushil very nicely showed that normal lateral condyle is bigger than the medial condyle. So it hits the lateral condyle bump and it doesn't fall into the trochlea, but usually it goes outside and it causes a patellar dislocation. So this is what happens. This just to show you what happens in case of okay, let me come back again. Okay, there is some problem. Let me describe some problem with the animation and the video. I don't know why. Okay, now it is coming. So if you see that the patella is coming down, knee is getting flexed. So if there is an internal rotation, the patella goes little outside and hits the lateral condyle and it falls back. So at this point, since the patella is coming in this direction, it hits the lateral condyle and the patella falls back. So if it is a internally rotated, whatever soft tissue you procedure you do, it's not going to last for a long time. The fifth cause, if the knee is valgus. So what happens if the knee is valgus is that the valgus knee will pull all the extensor mechanism towards the lateral side. So you see that if the knee goes into valgus, all the extensor mechanism has gone into the lateral side, and the patella tract from the sulcus line goes again to the lateral condyle, and lateral condyle obstruct its entry into the trochlea or the notch, and then you have a dislocation of the patella. Very interestingly, TTTZ distance has gained so much of popularity, and the TTTZ distance, which is more than 20 degree, indicates that your tubular tuberosity is more laterally localized. This is the groove, and this is the tibial tuberosity. If your tibial tuberosity is more lateralized, that means your TTTZ distance will be increased. So if your TTTZ is more placed lateral, again your pull to the patella towards the joint is lateralized. So since the pull to the patella is lateralized, since your pull of the patella, again because of the lateral location is lateralized, again it hits the lateral condyle and your patella falls into the lateral side. So you get a lateral dislocation of the patella. So if you transfer the tibial tuberosity medially, then what happens? The pull is directed towards the groove and towards the sulcus, and then your patella tracks normally. So what we have to understand, that the patella has a track which is in the femur, and the patella is not attached to the femur. Patella is attached to the tibia. So all the soft tissue or the track has to be normal, so that your patella tracks perfectly into the track which is prepared in the femur. So these were the 6 causes, and how to address that 6 causes I have described. Now I'll go to the second phase of my presentation, how to decide which surgery is appropriate for a particular patient. As I mentioned, that MPFL reconstruction will always be necessary. Either it is a torn case, or if it is not torn case, the MPFL is stretched, so the medial structures are not working well. So MPFL reconstruction will be required all the time. So except the MPFL, then you identify what are the structure that has been damaged, or that is the anatomy that has been abnormal. If there is a Patella Alta, then you supplement MPFL with the distalization of the tibial tubercle. If there is a trochlear dysplasia of grade C and D, then you have to supplement with the trochleoplasty. Only MPFL reconstruction is not going to help you out. If there is a rotational deformity either in the tibia or in the femur, then the derotational osteotomy has to be performed. Otherwise, the patella track on the different direction and the groove is in the different direction, so it is not going to help for any cause. If the knee is valgus, then the corrective osteotomy has to be done. If TTTZ ratio is more than 20, that means your tibial tubercle is more lateral, then the medialization of the tibial tuberosity has been done. So with this, I would like to summarize the whole concept in a gist by saying that the surgery decision depends on the pathology causing the dislocation. If there is only one pathology, then one surgery will suffice. If there are multiple pathologies, then you have to do a multiple surgery. One surgery is not going to tackle all multiple pathologies. So what do you do if there is a recurrent patellar dislocation? Number one should come in your mind, either the patient is skeletally mature or the patient is still skeletally immature. If the patient is skeletally mature, then you can do a bony procedure, you can do a soft tissue procedure. Whereas if the patient is skeletally immature, then you cannot do a bony procedure. you have to get away only by doing a soft tissue procedure. And if possible, usually if it is a valgus or varus deformity, probably a growth modulation can be instituted if the patient is skeletally immature. But what literature says at this moment, that if there is a bony deformity in a skeletal immature patient and you do a soft tissue procedure, in due course of time it is bound to fail. So do not promise or explain your skeletally immature patient saying that what we are going to do a soft tissue procedure today is a damage control, and in due course of time when you become skeletally mature, probably a definitive surgery has to be instituted. If you convince your patient, skeletally immature patient, in this way, there will be no disappointment from patient side as well as from the surgeon side. The second thing we must consider is either the dislocation of the patella is in flexion, or when doing a flexion 30-degree, or in extension. So if the dislocation is in flexion, that means it is not with the MPFL. Primary lesion is not MPFL. MPFL laxity has occurred because of the secondary lesion. So if it is in flexion, you have to do a bony procedure, you have to do a soft tissue procedure, and more importantly, if you do if dislocation is in flexion, the patella always goes towards the lateral side and the lateral structures are tight. So rather than releasing the lateral structure, you have to do a lateral side lengthening. This is very important. So if you have a dislocation in flexion, probably you must contemplate your all surgery along with the lateral side lengthening. If dislocation is in extension, you can do a bony procedure if it is a bump in the trochlea, or you can many a time get away with the soft tissue procedure. Let me elaborate a little bit what is a alla carte approach, that is most commonly talked about approach at this moment. Alla carte approach is you do as it comes, or you order a surgery. If one fails or one not enough, then you order another surgery. For example, this is just one combination. The combination may be varied. So if you done a MPFL reconstruction, that is not enough, probably you will again add a TTO. Now, if MPFL and TTO is not enough, probably you will again add a lateral lengthening. If all these three is not enough, then probably you will also add a trochleoplasty. If all these three are not enough, probably at end you will add osteotomy. So this approach to management of a complex patellar dislocation is known as a alla carte. Alla carte means order as per the need. So you do one. If it is not sufficient, you think that you need to do something more, then you add something. Is known as the alla carte concept. Now with this, let me share some of our experience. This is a very interesting case of a 13-year-old boy, repeated injury about 3 times all the time when he was playing football. This is the MRI. I do not have his CT scan. This is the MRI. You can see the sulcus is good. His patella was normal. There was no high riding. But what is important to see is you can see that the physis is not closed yet. So this is a 13-year-old outright. This is a skeletally immature patient. So whatever you are going to do, even if there is a, you can see that there is a lateral condyle dysplasia in the X-ray also. Whatever you are going to do is going to be a soft tissue procedure. You cannot contemplate with the bony procedure. So this is his, I'm sorry, this is his clinical picture. This is his clinical picture intraoperatively. I don't have a pre-operative, but you can see that knee is fully extended. Even in 10 degree of flexion, the patella goes laterally and it stays there. So the primary pathology in this case is probably MPFL. So we've decided to do a MPFL reconstruction. So this is a short movie of about 2 minutes. 2 minutes movie in which I'll try to show that what is my favorite method of MPFL reconstruction. This technique is known as the superficial quartz technique, which is described by my very good friend Deepak. And then In this one, you take a superficial quad, as Sushil clearly said that your superficial quad is a rectus, and rectus has attachment into the proximal patella. So you take a superficial rectus about 1 centimeter in the width, and then you continue dissecting it up to 10 to 12 centimeter of the length, so that you have a graft of 10 to 12 centimeter. So here what I'm doing is I'm trying to pull the graft and go up. So once I have reached about 10 to 12 centimeter above, you cut the proximal part so that you have a graft in your hand. Now, once you have started at about 1 centimeter above the superior pole of the patella, then you go down and reach to the superior pole of the patella. This is the right at the superior pole of the patella. If you see this graft, you can see that the tip is tapered and the base is little wider. So this is what the normal anatomy of the MPFL looks like. Once we have done a whip stitching, then you give a oblique cut, which is very, very important in the patella. I'll not go into detail of this technique because this is available in arthroscopy technique. So once you have done an oblique cut into the graft attachment side, you open the adductor tubercle side on the medial. Once you have opened the adductor tubercle, then you go from the layer which is between second and third layer. So underneath the vastus medialis, and then you bring it down. So the graft is being settled here. So at this point, if it is a skeletally mature patient, then we would have made this is how you have to suture your graft into the patella so that it doesn't move. So if it would have been a skeletally mature patient, I would have made a tunnel in the Schulte's point and fix this graft in that femoral tunnel. But since this patient is a skeletally immature, I've decided not to make any bony tunnels. So what we did was we identified the adductor tunnel. Again, to emphasize that Sushil was saying, the attachment site of adductor tunnel is very close to the MPFL. So loop with your graft into that adductor tunnel and suture over it. So the attachment of this graft, quadriceps graft, is in the adductor tunnel. So in this case, there is no bony violation is done. There is no tunnel in the patella. There is no tunnel in the femur. However, the MPFL reconstruction has been performed. And then you gently suture everything. This is the patient after 1 year follow-up. 1 year follow-up, the patient was doing all the things. He was not having any problem. He started playing his sports after 6 months of his injury. And then you can see that the patellar tracking is absolutely normal. Earlier, this patient had a nice J sign, but this time his patellar tracking after 1 year is normal. Now he's 7 years follow-up. The patient is still doing very good. This is another very interesting case and probably one of the most challenging case that we have performed. He was a syndromic 13-year-old guy. He was not able to walk on his one leg on the right side because he had a valgus knee. If you see this, he had an intoeing that indicates that there is a femoral internal version, and he had a persistent dislocation of the patella. It is not on this side. That persistently it is dislocated on the lateral side. If you see his CT scan, the axial cuts, you can see that there is no trochlear dysplasia in this. There is a nicely formed groove. The trochlea was normal. However, there was a lateral dislocation. Also, he had an intra-articular loose body, which has been removed at the time of surgery. This is the coronal cut, which shows that there is a valgus of, we do not have a scanogram. That time we were not having a scanogram of the whole limb. So there was a clinically and then appreciable valgus deformity in the CT scan also of the knee joint. So the plan for this patient was, since it was a persistently laterally dislocated patella, the lateral lengthening was planned. The patient had a internal rotation as well as valgus. So we decided to do a femoral osteotomy. Then we did a MPFL reconstruction, followed by Roux-Goldweth procedure, which is a medialization of your lateral part of the patellar tendon. So this was the patient. I do not have his intraoperative pictures, but this was the patient after 1 1 year follow-up, you can see that the fracture, the osteotomy site has nicely united. The valgus has been very well corrected, and then patient presented with this one. You can see that it was absolutely on this side. The patella initially was on this side. So it is very well located at the center. The valgus osteotomy has been performed from this incision, the same incision, sorry. That's why he is having a long incision. And you can see that the patient was so happy. And he said that I was not able to walk for so long, for 13 good years. Now I'm able to walk. Although it is giving me some trouble with the other knee, he was not willing to undergo any surgery on this side. He was absolutely comfortable. And you see that the in-toeing gait, which is present in this side, has also been corrected because of the rotational osteotomy. Another case, a 26-year-old gentleman, there was no trauma actually as such, but he was having a pain right knee and he was having difficulty in running. This is his scanogram. I have removed the lines, but his alignment of the upper lower limb was perfectly normal. If you see that there is a grade B dysplasia, but the sulcus was pretty okay. The trochlear dysplasia was little bit, but the patient had a high-lying patella. The patient had a patella alta, and there was a TTTG distance of about 24. So there was a little bit of lateralization of the tibial tubercle. The MRI also showing that. And this was his pre-operative. You can see on the left side, although he was having this on the bilateral side, but he was more symptomatic on left side. So he decided to undergo surgery on the left side. You can see that it was a J sign. The patella was dislocating on the extension. If the patella is dislocating in the extension, there are two things that is deficient. One is the patella alta. The other one is the MPFL is deficient. So what we did was to address the patella alta. We did a distalization and the medialization of the tibial tuberosity. And here you can see that the screws has been used for distalization and the medialization. And then we did a same with my favorite technique of quartz, superficial quartz technique. This is the graft harvested, very nice for the MPFL reconstruction. This is a video just to show you that how nicely when you bring the tibial tuberosity downwards, the patella also come down. You see that? You pull this after excision of this much of fragment, the patella also come down. So it medializes as well as distalizes, which take care of so many things that the patient was having. And this was the incision for MPFL reconstruction, these two, and this was for the tibial tuberosity transfer. This was the after the surgery. You could see that about 5 millimeter of the tibial tuberosity has been distalized. And this is the patient again follow up after 14 months. You can see that the osteotomy site has very nicely been healed. The scars are pretty okay. And this is his post-operative picture. This is the healed scar of the distalization. This is for the MPFL, and you can see that you can compare the unoperated side with the operated side. You can see that the J sign positive on the unoperated side, whereas the J sign is completely negative on this operated side. And this patient is scheduled for surgery on this side as well very soon. My last case, which was probably the latest very difficult case we did about 12 months ago. This was a very young 26-year-old lady, and you can see scar all over her knee. 2 on this side, 2 on this side. So she underwent 4 surgery earlier to maintain this patella into its location. And she was not able to extend her left knee actively, and it was very difficult for her to stand from a sitting position because the patella was always going out and the extension mechanism was not functioning. So if you see this lateral X-ray, though these are not true lateral X-ray, but in this lateral X-ray also you can see that there is a double condylar sign or overlap sign that indicates that there is a severe grade of the trochlear dysplasia. And the previous surgeon has neglected this severe grade of trochlear dysplasia and done a soft tissue surgery. So when you do a soft tissue surgery, neglecting this bony lesion or the bony anomaly of the anatomy, it will last only for a short duration. It's just matter of time when your soft tissue procedure is going to fail if you do not address this bony pathology. This was her pre-operative X-ray. You can see the trick that she is not able to. This is her right knee, also have dislocation inflection, but she was actively able to extend. But this she is not able to extend actively, and she uses this leg to support so that this can be actively extended. So this was a lady. So we decided in this case to do a lateral lengthening because it was a persistently dislocated lateral lengthening. I'll not go into detailed steps of the trochleoplasty, but this is the trochleoplasty we have done in this particular case. We have excised the bump from here. Now this is the cartilage flap which has been elevated, and once the sulcus has been created, this will be put back so that a new sulcus or the groove, trochlear groove, has been created. So the patient received trochleoplasty, and then at the same time we did the quadriceps superficial quads technique and reconstructed the MPFL. And this is after the reconstruction. Though the wound looks very much extensive, the patella is gliding on track. Now the track of the patella and track of the femur are matching with each other. And this is 8 months follow-up case. You can see that she was not able to extend by herself. Now she is able to extend, and the patella track is very nice. Whereas in this side, there is still dislocation inflection, which is very, very important to understand. I'm trying to emphasize. And she has been scheduled for next month surgery on the right side. And she is one of the most happiest lady whenever she comes to me and say that the 5th surgery finally worked, and she want to get it done on the other side as well. So to conclude my presentation, which become little lengthy, I guess, but I think it is worth spending some time on the darker side of orthopedic surgeon, which is recurrent dislocation of the patella. And I'd like to conclude by saying that a single surgery cannot tackle all the problems. So the recurrent patella dislocation is a multifactorial. Identification each and every factor is essential to plan the treatment. Each anatomical abnormality has to be treated. It is not that one surgery will take care of all the anomaly. If there are multiple anomalies, multiple surgery. Only one anomaly, one surgery. And the most important point is soft tissue reconstruction cannot compensate the bony abnormality. If there is a bony abnormality, the soft tissue component is not going to hold your patella into place. It is going to fail for some time. So it is utmost important to identify the bony abnormality, exclude the bony abnormality before you take on a soft tissue procedure. With this, I'd like to thank NOA Chitwan for having me and trying to explain certain basic aspect of recurrent patellar dislocation. Thank you very much.